So this kind of situation we encounter frequently, replacement of lower molars, heel area. So what things to look? Heel case, both 6 and 7 we are replacing.
Lower, what are the plan, sir? Now, present?
The lower molar and the upper few molar. Now first we will discuss the lower molar. So this is 8 is impacted, we are not going to remove it now. So either 2 or 3 implant will be okay. So what is the quality of the crestal cortical bone? Whether it is thick or thin, what is the quality of this intramedullary bone? Where is the canal? And what is the buccolingual width? So these are the 4 important things. Apart from that, what is the angulation of premolar? That is the most important thing. If it is straight, it is okay. But if it is tilted, so when we are drilling, we may go close to the premolar. So this thing we have to check. So we have to drill either like this, or either we can drill like this. So if you place implant straight, we have to start the drilling very much away from the tooth, so that we are not touching the root apex. So this distance will increase. Otherwise we have to do like this, to slight mesially tilted implant. So that will be a better plan. So mesially tilted 2 implants. It is not possible to place a third one without removing or without interfering with 8. So ideally 6 and 7 better to place 3 implants. But here since 8 is there, we are placing only 2. Otherwise we have to remove 8 and we can place 1 implant almost close to the distal root of 7. So what is the diameter? Either 4 or less than 4, right? So that depends on the buccolingual width. So how will you see the buccolingual width? If CPCT is there, we can see before itself. Otherwise we can open the flap. So since we have CPCT, we can see before itself and we can do flapless for this patient. There is no need to open the flap. But if there is no CPCT, if you want to be more sure, then a small flap, it is not a matter. So the width is determined by the buccolingual width, 4 or less than 4. And height, where is the canal? Maybe this one. The canal looks far away, so 10 mm will be fine. Okay. So how to confirm it? One way is to take CBCT. Otherwise, you can take a IOPA. Don't measure the length on panel. Okay. So take a IOPA that is more or less accurate. This is the canal. Give 2 mm safety distance. Then from the crest to here, measure it. So intraoperatively, you cannot select the length here. Intraoperatively, you cannot select. See the IOPA or see the CBCT before itself and finalize whether you are going to place 8 or 10 or 12, whatever it is. Mostly it will be around 10. Either if the buccolingual width is good, 4 into 10, here 4 into 10. If the buccolingual width is not good, less than 4x. Any brand is okay. So almost 90% of the planning is over with the pano itself. So the most important thing is the premolar angulation. Even if the premolar is straight, imagine even if the premolar is straight, when we drill, what doctors do, yesterday I observed when he was doing, the drill is moving like this. This wrist movement will be there. So they will start here, we will start here. When we are going deeper, it makes a curve. So the final product will be like this implant. You can see many x-rays like that. The mesial implant of 6 will be close to the root. So always lock the wrist. Lock the wrist and go like this. Not like this. Okay.
Resistance
Yes.
automatically detected.
Yes. That mistake we should avoid. So make sure you are not making a arc like this. Go like this. So we will confirm our plan. See the outline. There is mylar ridge. Even in the mesial root of molar, first molar, we are seeing mylar ridge. The crestal cortical is good, right? It is around 2 mm. So our implant will be taking main support from this crestal cortical. And we don't know where is the nerve, right? Mostly it may be the nerve. This is the deepest point. So what is the length from here to here? Here, even till here we can place. So placing implant like this is one plan, or placing implant lingual cortical is also another plan. So we'll see the crestal cortical value. It is around 946. The lingual is around, so either we can go like this. Around 14 mm length is there. First we will finalize the canal, we will find the canal. Mostly this may be the canal. But below this, depression. So even if you are reducing 2 mm, you can place up to 13 mm, but 12 is enough. So 4 into 12 we can place intramedullary, or we can tilt, place a longer implant. I'm getting lingual cortical. So this is one plan. Another implant, distal. What is the situation here? Here you can see the crestal cortical is much thinner than the more fully radiolucent. So whenever you see this kind of complete radiolucency, that means the vitamin D is gone. Okay. Invariably they will have vitamin D level less than 10, 6, 8, something like that. So along with the implant placement or before implant placement, start vitamin D replacement weekly once. Before how many units? 60,000. 60,000. Okay. Here we can try lingual cortical, but the problem is while bending, no, this is very weak now. This may crack. So we will place intramedullary and we will do welding. And so this kind of doubtful cases, what we do is we place the implant, we do welding and tell delayed loading to the patient. Because this is a very soft bone. If you give tooth immediately, then there is a chance that no, it may fail. Not for full mouth. This kind of one or two implant, 3 implants. Delayed loading is 2 months later we will give the crown.
Till then implant will be
The
there.
implant will be there outside. Nothing will happen. Okay. If we place a conventional implant, that is also a good option for this patient. To conventional implant. The problem with the conventional implant is there is one complication. No, we should be careful when we are doing conventional implant. Suddenly the implant may go inside. Okay, if you keep the implant here, it will be stable, this 1 mm bone. If you just over insert, the implant will be lying here. Have you seen those x-rays? The implant will be lying here, like this. If there is a good bone, the implant won't slip like this. It is like a sinus cavity. The same thing. So even when we are placing a single piece implant, when the implant head is here, you will get some stability. But the moment you insert deeper, the implant head now will come here now. When this part goes below that crestal part, it will immediately become loose. Yes. So when we are placing implant with single piece, make sure you are not over inserting. Make sure this is the gum. Make sure this is staying back. The moment
Basal, are you going on basal?
no, compressive one. Basically, it won't get any support here. Where it will get support. So what we can do is the distal implant we can do crestal, intramedullary, and the mesial implant we can do lingual cortical. Okay, so that at least one implant is more
You
crestal.
said 12 o'clock patients, sir?
No.
Yeah.
No. Same patient, we are going to plan the upper one.